Morning, ladies and gentlemen. Welcome to this very important session on challenging tuberculosis in urban settings and big cities in comprehensive TB control programs. My name is Dr. Siyum Dejene. I work with USAID in Uganda. I'm advisor for HIV and TB programs. I'm co-chairing with my colleague.
Good morning. You are very welcome for this important symposium, and thanks for coming for this symposium. My name is Pedro Suarez. I am the Senior Director for the Infectious Disease Cluster at Management Site for Health based in Arlington, in Washington.
Okay, thank you. Before we go to individual presentation, just want to say a few words why this session is very important. In terms of the challenge of TB in urban areas, as you all know, there is increasing urbanization. The world population was reported to be 3.8 billion in 2013. That number is going to rise to 6.3 billion by 2015. 50% of the world population is living in urban areas. And also, over the last 2 decades, the incidence of TB in urban areas is on the rise. So there are multiple factors that are creating this situation in urban areas in terms of poor TB control programs over years in these urban areas, and also there is a rise in different risk factors in terms of populations living in urban areas. So we are going to have 4 presentations from Uganda, Afghanistan, and there is 1 presentation looking at the TB program in Latin America, and also 1 presentation from the UK. So just to double check, I've seen presenter from Uganda, Afghanistan, Latin America. I didn't see the presenter from UK. Okay, so you're welcome. Let me invite the first presenter. It's a pleasure to invite Dr. Frank Mugabe. He is the National TB Control Program Manager for Uganda. Dr. Mugabe has more than 16 years of clinical program management and leadership experience in the area of tuberculosis and tuberculosis management. During his tenure as National TB Program since 2012, program manager, he made a significant improvement of the TB program. The treatment success rate increased from 71% to more than 80%. The cure rate increased from 22% to 55%. And the ART uptake for patients with TB HIV co-infection increased from 25% to 80%. So these are just few successes of Dr. Mugabe. Dr. Mugabe, you are welcome.
Thank you.
So the topic for the first presentation is strengthening TB service provision through urban nodes in Kampala, Uganda.
Thank you. I'm privileged to share with you this presentation on behalf of the team that has supported TB control in Kampala. Just a brief background about the TB control program in Kampala, in Uganda. We're a high burden TB HIV country. We have a population of 35 million. Our annual notification is about 46,000. We are notifying about half of the actual burden. The prevalence is now at 253 per 100,000, just after the prevalence survey. And our treatment success and cure rates at 8 and 55. We have a high TB HIV co-infection rate. though we have seen it come down from about 60% in the 2010 to now 41. Coming to Kampala, Kampala has a resident population of about 1.5 million people and 3 million during the day. It notifies between 16 to 18% of the cases. It has a higher HIV prevalence rate, more than the national one, which is at 7.2, and a high TB HIV co-infection rate of 50%. In 2013, we had about 38 facilities that were providing TB services, and we had only 8% of the patients who were documented to be on DOT. The treatment success was 64%, and the cure rate was 30%. There was visible poor coordination of stakeholders, poor recording and reporting, and limited engagement of the private sector. And there was almost no community linkages with the health facilities. Some of the key interventions that were done from 2013 included formation of a Kampala TB task force, which included a number of partners, the Ministry of Health, National TB Program, the different projects, Track TB, the Union, IDI, FIND, Interreligious Council, AIDS Information Center, and others. And from this, an urban dots model was developed. And after this, the number of facilities that were providing TB services were also increased. We are privileged at that time to have a Spark TB project, a TB reach that brought on board quite a number of private healthcare providers and a number of standard operating procedures that defined case detection and treatment and the involvement of community health workers, the ones we call community linkage and facilitating officers. We took a deliberate step to strengthen the monitoring and evaluation component, introduced an electronic data system, and implemented monthly reporting of data from different divisions. Ordinarily, the TB program collects quarterly data. So monthly reporting data was very good in alerting the division focal persons and other people in knowing where they are. Strengthened the component of community DOT with community linkage facilitators. There were over 40 of them. And you know, in an urban setting, people don't know each other. People live in gates, so breaking into those gates is usually one of the limiting factors. These people facilitated home visiting. They are given airtime to call the patients. And we also operationalized patient appointment registers. At some point in 2014, we brought in the quality continuous improvement initiatives, starting with about 6 facilities and expanded it to over 30 major diagnostic facilities by the end of 2015. This is a schematic drawing of the urban DOTS model in Kampala. You can see it has the health facility here at the center. These are the directorates of health services. This is the patient's home and the treatment supporter, and these are the division offices. This is the community linkage facilitator who moves to the home and moves to the health facility, and also from the health facility reports and other support comes in and to the division. These ones help in ensuring that there is supervision and implementation of the agreed on activities, including coordinating the Kampala task force activities. So this model helped a lot to bring the different stakeholders together. We saw the number of health facilities increasing, including seconding some private health facilities to provide free TB treatment, to receive free TB medicines, increasing from 38 to 93 facilities, a mixture of both public and private. We saw the documented DOT coverage rapidly increasing in 3 years from 8% to now about 83%. And we saw the treatment outcomes definitely improving. You can see how the lost follow-ups declined from 26% to 12% just in 1 year, and leveled down to about 5%, which is just 1% above the acceptable national level, which I think is a landmark achievement. And we also saw the cure rate. Usually, cure rate had been our problem as a country, and our biggest problem was documentation, but we saw the cure rate narrowing towards the treatment success rate, which is now at 87 and cure rate at 78. We saw the ART uptake, which is the green curve, raising from above 56% up to 95% in a very, very short time, just 2 years. And of course, we have one biggest challenge that we have to address, which is the case notifications. We have not seen, despite all of these, we have not seen our case notifications raise. But we know the problem. Our problem is that we are diagnosing bacteriologically confirmed TB, and we have had limited investment in diagnosing clinically diagnosed TB. And we also have other challenges, one of them being the mobile population. The users of the services in Kampala are not necessarily the people who live in Kampala. We still have a very large private sector. Actually, in Kampala, there are about 2,000 private health facilities. We are able to add about 50 of them. So we still have room to engage the private sector much, much more to benefit TB control. There is a very high turnover of health workers. Kampala is largely slummy with very poor housing facilities. We think these propagate the transmission of tuberculosis. There is a very high HIV prevalence. And of course, we cannot forget talk about donor dependence. When we register such success, we get worried because we want such success to be sustained if we are to impact on the epidemic. We think that we can do more to improve. We want to review the urban dots focus, now shift on contact tracing, focusing on children, address TB, HIV, and TB in slums. We would want to add on more private health facilities. With the new knowledge now from the prevalence survey, we think if we invested in digital X-ray services and did some mobile outreaches, especially for close contacts of confirmed patients, HIV positive, prisoners, and other groups, we could do more. We definitely have to improve the health work capacity to clinically diagnose TB. Not every TB is going to be bacteriologically positive in view of the insensitivity of the tools that we have. We have about 20 gene expert machines in Kampala, and recently we thought that we would do a direct gene expert test. So if this one is coupled with improved sample referral, I'm sure we shall be able to ease diagnosis. And we need to create awareness and implement also the one-stop shop for TB and HIV services. I want to thank, of course, the government of Uganda the KCCA, our partners, USAID, the Union, our projects, Track TB, IDI, and the health workers, and of course the patients and families that have been cooperative in this arrangement. Thank you very much.
We're going to have the questions at the end. So you may sit.
Let me introduce to the next speaker, Dr. Mohammad Siddiq, who is the NTP manager from Afghanistan. As you know, Afghanistan is a very difficult country to work. However, under the leadership of the Dr. Siddiq, during the last at least 7-8 years, the NTP in Afghanistan can show very important outcomes, as he will demonstrate. This presentation was prepared jointly with Dr. Mohammad Rashidi, who is the Challenge TB MSA's project director in Afghanistan, but unfortunately he is not present in this symposium. So, Dr. Siddiq, the floor is yours.
Thank you, Dr. Petro. This is my pleasure on the behalf of NTP team of Afghanistan and on the behalf of Afghan Challenge TB colleague, I have this presentation. The first slide, the data, as you see, unfortunately, due to security situation since 35 years, we do not do any prevalence survey. And every year we are using the data which is reporting by Global Fund, WHO global report, but all the data is not as an estimation of data. Based on UN, the total population of Afghanistan is 33 million. Incidence of estimated incidence is 189 cases per 100,000 population. Estimated prevalence is 340 100 per 100,000 population. Estimated mortality 37 cases per 100,000 population. Treatment success rate 87%. Case notification rate for all TB cases is 129 per 120 population. Case detection rate for all form is 62%. Percentage of women affected by tuberculosis as a sputum semer positive, 63%. Women affected by all TB cases is 58%. Dose coverage population on the health facility is 97 and 76%. According to the government distribution, Afghanistan have 34 provinces, and Kabul is the capital of Afghanistan with the population of 4.5 million. You know, in every main city they have crowding, high population density, poor sanitary facilities. But you see the situation in 2009 in Kabul city. In 2009, the case notification rate was 26%, conversion rate was 47%, and treatment success rate was 49%. With poor dose coverage, you know, out of 134 health facilities, just 22 health facilities providers working for tuberculosis. And the other issue is poor public health infrastructure, weak primary health service, and unregular private sector. You know, it's a very danger for health in Kabul city. The decision of NTP and NTP partner and stakeholder was that for the establishment of a new intervention by the name of urban dots. The first strategy which we discussed was that we discussed the establishment of urban dots in Kabul city with the NTP partner and NTP stakeholder. And the second issue, we developed it as a strategic plan for urban dots for the implementation. Introduction of urban dots approach to Ministry of Public Health, because you know for any intervention they need a TB program for political commitment, and this purpose we discussed it with the high leadership of the Ministry of Public Health, national and international stakeholder. For example, the WHO, JICA, Global Fund, Stop TB Partnership of Afghanistan, and other government ministry, because they are as a member of a Stop TB Partnership of Afghanistan. Finally, for the better implementation of this intervention, we developed it as a SOP for case detection, SOP for treatment, and SOP for case infection control. The second strategy for the implementation of urban dots in Kabul city, there was a planned training for public and private sector, regular supportive supervision for healthcare worker, ensuring regular supply of drug and laboratory supply, because you know for the health facilities belong to government, there is no problem, but when we move to private sector and private hospital, NTP is done as an MOU between two parties. NTP is provide for private hospital free of charge anti-TB drugs, free of charge of recording and reporting format, and free of charge reagent, microscopic reagent. We established it as a regular quarterly review meeting or review workshop, reporting and monitoring evaluation, expansion TB services in the new public and private health facility, launching awareness raising campaigns. This is very important for us because in 2009 we started the new intervention by the name of urban dots in Kabul city. You see all health facility providing dots in 2009, and you see the end of 2000, because you know the data of 2006 is under process. We not put it here, but the number is year by year is increased, and also the number of health facility with the lab services. You see the 2009 when we compare with 2015, and the health facility covered by dots. You see there's a trend is increase 2009 up to 2015. And this is a trend of case notification in Kabul. The total case, because you know there was a 3 project of MSHUA SID. The first project was started from 2009 up to 2011 by the name of TB Cap. Other project is started from 2012-2014 by the name of TB Care, and the ongoing project is Challenge TB started from 2015. But you see, for example, during the TB Cap project, the total number of cases which is notified by urban dots intervention, but finally there's a total number of 5,449 cases. New bacteriologically confirmed, reiterated bacteriologically confirmed cases. This is a sort of trend, but some of trend is now is decreased, and we not put the 2016 data. This treatment outcome from new bacteriologically confirmed TB cases 2009-2014. You see the cure rate, treatment success rate, failure rate, loss of follow-up. Because you know the main problem of when we established urban dots in Kabul city, there was a loss of follow-up. Because you know Kabul as a capital, every patient, they have interest to come to Kabul. But when they are diagnosed in Kabul, after sometimes they are disappear. But when you see in 2009, the not evaluated, as was 46. But during the years, this figure has decreased to 19. This is Urban Dots achievement. I'm not touched to another years, but just as a baseline, our baseline is 2009. I compare the 2009 data with 2015. You see the number of health facility implementing dots in 2009 was 22 health facility in all over the Kabul city as a capital of Afghanistan. But in the end of 2015, the number became to 85. But now the numbers is increased. We not put, as I told you, the number for figure of 2016. Number of presumptive TB cases identified. This a number in the end of 2015, 17,525. Number of all form TB cases notified, 5,449. Number of laboratory confirmed TB cases notified, 1,449. Numbers of all form TB cases notified among children, 1,129. And also you see that this number in 2014. In 2014, we purchased a digital X-ray machine through Global Fund. When we installed this digital X-ray machine in one of national pediatric hospital by the name of Indira Gandhi Children's Hospital. And based on the installation of digital X-ray machine, we found many TB cases. Bacteriological confirmed, yeah, this a percentage. Treatment success rate, you see in treatment success rate in 2009 was 49%, but in the end of 2000, but has not got the 2000 treatment success rate. And treatment success for all TB cases is 40, and you see in the end of 2014 is 65%. Urban Dots achievement, number of evaluated cases, household contact. We started this intervention in 2012, and when we compare the data, you see in 2015 we have 6,040, and the number of presumptive TB cases among household contact is very important for us. And 2012 was 195, but you see in 2015, 645. Number of cases notified among household contact, 18, 53. Number of children below 5 years old, 415, 836. And the children, they are receiving under 5 years, they are receiving INH preventive therapy. And 2012 was 119, and the end of 2015 is 765. The key result of establishment of Urban Dots as a key intervention in national TB program in Kabul city as a capital, as I told you, you see the dose coverage of all its facility increased to nearly 300%. Detection of presumptive TB cases increased overly is 500%. TB case notification for all form increased to nearly 200%. And number of bacteriologically confirmed TB cases notified increased by 78%. Conversion rate of bacteriologically confirmed TB cases up to 47% to 73%. Treatment success rate, bacteriologically confirmed, as I show you, in 2009, this treatment success rate was 49%, but in the end of 2015, is 47%. This is a main challenge, poor communication of private and national hospital staff, because you know this in every country is ongoing. Unregulated private sector and private practitioner, because so many times we discuss it with private sector to introducing TB suspect cases to nearest TB center, and we arranged many symposium workshop, but unfortunately when we see like past, they are doing own business. I turnover of staff, healthcare staff, this is happening mostly in majority of in the government side, because when there is not interest working or due to security situation, they are changed province to another province or they are left job. And the main issue is that easy access to low quality anti-TB drug in the market, because you know Afghanistan has a large cross border between two neighbor countries, Pakistan and Iran. Inside of Afghanistan, we not produce anti-TB drugs, but the majority of anti-TB drugs, they are marketing from two neighbor countries, Pakistan and Iran. And unfortunately, in all over the pharmacy which is exist in Kabul city and other provinces, when the GPS prescribe anti-TB drugs, they are easily get anti-TB drugs. No standard building of health facility, and especially this is happening in the national or government side, because there is no standard, especially in Kabul city as a building. They are renting, and also, you know, when we start for the rooms for tuberculosis, and also when we set up some measure for infection control, but when they are go to another rental houses, also there is growing problem in the front of national TB program. Low community awareness on TB as a digital stigma, but before in 2009, when the TB cap, TB care and challenge TB, we used the money of the project for the awareness of reducing the stigma. Poor capacity of diagnosis and treatment extrapulmonary TB and TB children, but fortunately by the support of Challenge TB this year, consultants came to Afghanistan for developing as a SOP for extrapulmonary. They are jointly NTP and Challenge TB they developed, but now they are under process. And at the same times we developed another SOP for diabetes and TB. Also there's a consultant from Challenge TB came to Afghanistan for supporting NTP Afghanistan to develop such a kind of this SOP. I transfer out, as I told you, that normally they are come on all over the country to cover. Way forward, improve multi-sectional approach, that's the main of National TB Program of Afghanistan. Improve number of private health facility, implementing those in public-private mix. This good model for Afghanistan, and we expanded this model to another main provinces. Improve case detection, focus on high-risk population, contact children, internally displacement, prison. orphans, TB diabetic patient, as I told you, the SUP is under process. Introducing GenExpert and digital X-ray machine through Global Fund. We purchased 4 GenExpert machine, and 1 GenExpert machine is donated by JICA project to National TB program. We installed the GenExpert machine is 1 to Afghan Japan Communicable Disease Hospital, and the 4th we installed it in our regional reference laboratory. And also at the same time we purchased a digital X-ray machine. 4 machine is purchased through Challenge TB, USAID MSH, and 2 through Global Fund money. Improve the quality of diagnosis, especially in extrapulmonary TB and TB in children. This is the top priority of National TB program of Afghanistan. This part was, as I told you, we developed it as SOP for extraordinary pulmonary. Improve reporting system in using mobile phone through Challenge TB project, and to reduce the no evaluated risk, because when the patient is not come, immediately the person who is in charge of this activity, they are called, and also to ask the patient why, for example, you not come for pick up your drug. Thank you.
Okay, thank you very much. We'll wait for the question to the end. Can we help those who don't have seat to get seat? There are some colleagues sitting on the stairs. Let's take a few seconds to help them. Let me introduce the next presenter. Our next presenter is Mirta del Granado. Mirta, she has been serving as the Pan American Health Organization regional advisor for TB. She's a doctor with specialty in immunology and public health. Prior to working as TB advisor for Pan American, she used to be the national TB program manager for Bolivia. Mirta, you are welcome. And the topic for her presentation is TB in urban setting, in big cities in Latin America and the Caribbean. So she's covering a large number of countries. I tried to Google the big cities in Latin America this morning, like about more than 50 big cities, and total population more than 120 million. So I think this is she's covering a big portfolio. You're welcome.
Good morning. First of all, thanks to the union for Dr. and also thanks to Dr. Sejen and Dr. Suarez for the invitation. I apologize, I'm not very fluent in English, but I'm going to try my best. So I'm going to give you an overview what we are doing in the Americas. I will begin with the challenges that we have in the Americas in TB control, and one of it is the missing cases that we have. As you can see, we are missing 50,000 cases, and the big question was and is where are our missing cases? The other challenges that we have also is the epidemiological transition. There are the increase of non-communicable disease, diabetes, for instance, alcoholism, drug addiction, smoking. It's a big issue that we are going to face in the future. For instance, I present some data from Mexico, and as you can see, 23% of TB patients have also diabetes, so it's a huge problem. The demographic changes also because we have aging population, and as you can see in the graph here, for the Andean countries, the incidence is very huge, very high in population for more than 55 years old. The increase on rate of migration, the migration changed also in Latin America. Most of the countries, the migration is more south-south, saying that the poor countries in South America are going to richer countries in the same region. And also the increased rate of urbanization. So we were trying to respond our question, our initial question, that it is where are our missing cases. It was said already that one of the regions more urbanized in the world is the Americas, and especially South America in 2014 had 83% of rate of 83% of population living in cities. In general, the most than 80% of Latin America population lives in cities. So when we were talking about whether our missing cases, we review the data that we have in some cities in the region. And as you can see, for instance, in Lima, Peru, and Montevideo, Uruguay, these two cities concentrate the 60% of all notified cases in the country, and more than 80% of MDR-TB cases. So the question is, the response is that most of our cases certainly are living in cities. What is the impact of rapid urbanization in the Americas? The economic activity is concentrated in cities. The GDP, 60 or 80% of the GDP is produced in cities. The relative incidence of urban poverty is decreasing, but the absolute numbers of poor is increasing. In 2012, it was estimated that 127 million were poor. One out of every 4 urban dwellers is poor. 27% of the population lives in slums. It means more or less 117 million people. Also, we can say that the provision of drinking water, sewage management, and electricity do not reach all the poor population in cities of lack. So, having done the analysis at PAHO level, we perform a lot of meetings. We invite the NTP managers to analyze what are the problems that we have in the cities. We also have some meetings with experts in urbanization. At the end, we decided to do something together. The first thing that we needed to do is to analyze the main barriers to TB control in large cities. So at the end, we recognize, very well recognized, 7 main barriers. One is the fragmentation of multiple health providers. The second is multiple health authorities. As you know, we have the authority of the Ministry of Health at the city, the authority of the municipality, the authority of social insurance, the authority for prisons, the authority for military. So we have a lot of authorities that we should coordinate. Lack of comprehensive health services. So in the Americas, we have a big problem. HIV, for instance, is the care of HIV is at 2nd and 3rd level, and TB is in the whole health system. So that's a huge problem. Diverse patient population. Most of the ethnic minorities are living in slums, and these populations have their own beliefs, habits, and customs. The other is the poverty and marginalization. So a lot of the people in the slums have a limited access to the health care. The lack of an intersectoral approach to improve basic living and health conditions. I told you that the poor they don't have access to the health service, but to the other services. And violence in large cities in Latin America, because the most dangerous cities are in Latin America. It's also a big problem in the access of the health to the health care. So at that time, the big question was what we should do differently in TB control in cities. First, we need to do a situation analysis, identify areas with high TB incidence, identify the coverage and quality of health care, the political commitment of health authorities and others outside of the health system, the community and civil society engagement. So we discuss these topics with the TB programs, the TB programs manager, and following all this feedback, the TB team at PAHO wrote the framework of tuberculosis control in large cities of Latin America and the Caribbean. This framework has 8 components. One is referred to strengthen the political commitment, they conduct epidemiological mapping of TB situation, to survey and map the health system and existing healthcare providers, to adapt healthcare to the needs of the risk population, to take an interprogrammatic approach to TB control, take an intersectoral approach, and include the TB patients in social protection programs, promote the civil society engagement, establish a routine monitoring and evaluation system. You see the map of the Americas. The red points are the cities that are implementing the framework. So the steps for the implementation were set up a committee for TB control, conduct a situation analysis that I talked already, and develop a work plan for TB control. So what I'm going to present to you is the initial implementation framework for some effects in the implementation. One is the political commitment, and as you can see here, it's Bogota, Colombia. We initiated with the localidad that it is called, that it's a small municipality in Bogota, but after 2 years, it was expanded to all city, all Bogota, and as you can see, the trend, the increase in funds coming from the local authorities was very huge. Dr. Moreno, the NTP manager, is here from Colombia. Maybe he can also talk about that, but it's a very nice experience that we have in Colombia. The other is the cities identify the areas of intervention and at-risk populations. I can show you some experiences. For instance, in Lima, Peru, we perform also the epidemiological mapping. So we use the indicator of incidence, and also we use other variables, socioeconomic variables. And they decided where to implement, to initiate the implementation of the framework. And as you can see, here is Lima, Peru. And also we present Montevideo, but also the health system, we map also the health system and the informal providers. We map the private, the public, and the informal providers, and also we did a survey to these providers, especially for informal providers, to be involved in TB control. I show here, for instance, in Montevideo, that they decided to work in these municipalities, and also they did the reference, the geographic reference of the patients, and the points black are the patients in this city, and the heart here are the hospitals that are taking for TB control. In Uruguay, it's a very centralized TB program, and they thought that that they were doing very well. But in Uruguay, the incidence it is going up, and it is due to Montevideo. And they realized that the hospitals where they are taking care of the patients are very far from the patients. So and also they analyzed that the diagnosis is very delayed, one, and the other thing is that they didn't have children with TB. Now they have even meningitis with TB in children. So they need to adapt this care to the needs of the patients. That's what we are doing in the other cities too. Also, the countries are using an integrated approach of TB care. So that's not completely, we are working on that, but it's very important to know that, for instance, diabetes and TB, it's very integrated in Mexico. They are offering these two services in the health facilities. We have some improvement in TB, HIV. It's our best problem in the region because we have problems to integrate, but Peru is working on that, and it is doing good job. Mental health and TB, it's a big problem in the region. Colombia is doing an amazing work on that, but we need also to improve this work. And tobacco and TB also is implemented in Brazil. The idea is to have all the services should be integrated to offer the care to the patients when they go to one service. TB was included in intersectoral committees. Lima and TB patients are included in social protection programs. So Here you have a multisectorial committee who is sitting there in this intersectorial committee. These intersectorial committees are at local level, and they are sitting representatives of the minister, different minister, education, health, working, etc., social area. So, and they have plans. So what they did in Peru is to analyze their plans and to introduce in each of the representative something about tuberculosis. It's a very hard work because it's not easy to do. The government change, so these representatives change. When the local government also change, these representatives change. So it's a very huge job, but we are talking more and more about tuberculosis and other sectors. The other is the social protection programs. Most of the countries are introducing TB in the social protection programs of the national level. It's the policy of the country. It was amazing when we had a meeting with Uruguay. In this meeting was the Minister of Health and a lot of 2 or 3 ministers of the social area. When we exposed what's happening with TB in Uruguay, it was automatically the possibility to introduce all the TB patients in social protection programs. Also, the civil society was engaged in TB control activities, and in Guarulhos, Bogotá, TB mortality committees were established. Monitoring and evaluation of this framework, the most important indicators are also incidence and the trend of incidence, mortality and the trend of mortality, the cure rate, of course, the cohort analysis, and also the case fatality rate. So for this, the Guarulhos and Bogotá, they established this mortality committee, and it was amazing results that they presented. Here I can show some data. For instance, in Guarulhos, they increased the detection, but the mortality, you see here there are some data, but when they cross the data with the vital registration, they showed that they were 67 notified deaths, and they also had 37. So there were a lot of there were some deaths that were not inside this in the notification register. So what we saw after the analysis of these TB deaths is that most of them were, they died at the hospital level, at the emergency rooms. So we saw the delay in diagnosis. They also do some focal groups for analyze the barriers of TB control, and the most important barrier was the schedule of the health services. So they are working also on that. So what are the lessons learned so far with this initiative? That TB control in cities becomes an important part of the agenda of the Ministry of Health and of local governments. The framework has been owned by national and local governments in the 8 countries of the region that has been implementing the initiative, and it is now expanded to other cities in pilot countries like Colombia. The initiative could contribute to eliminate the TB catastrophic cost for TB patients in city, and I have to say that we don't have a lot of study of catastrophic cost, so we are pushing because maybe it's going to be a good indicator also to see how this initiative is implemented. And community involvement facilitates the implementation of the framework and gives it more ownership. What are the next steps? Promote the expansion of the initiative to other cities and countries. Our example is Colombia, that it is expanded to all Bogotá, and now it's expanded to other cities like Barranquilla, Cali, and Medellin. And TB control in cities also is put in the public health plan. They reinforce the introduction of the initiative of TB control in big cities in global fund grants that we have the commitment with the global fund, from the global fund to push this initiative, and discuss with the NTPs how to better approach TB control and hotspots within the cities carrying out the initiative. So what we do is the analysis to try to organize things, but we are also thinking that we have other problems like hotspots. At this moment, we are performing the evaluation of this initiative to having more data and maybe to review also our framework. I want to thank you, and a special thanks to USAID. The USAID permit us to do this initiative and to implement this initiative, and also the colleagues that are working in this initiative. Thank you.
Thanks, Mirta. Thanks so much. So if you see in the program, we have included a presentation from Peru, but the presenter couldn't participate in this conference, so we are quite flexible in terms of the time for the presenters. And now let us move to the presentation from the experience in UK. Al Story will present the experience that is will share what are the situation of some of the high-risk groups of vulnerable populations here in UK. The floor is yours.
Thank you very much, and good morning. I'm going to try and keep it brief because obviously it's a great opportunity for discussion rather than just listening to me rattle on. But I'm going to try and give you a very clear message by using London really as a window into really what's happening in the world. London's a big city. It's the largest city in Western Europe. It's twice the size of the second biggest city, Madrid and Berlin. It's about 9.2 million people. And it's got an interesting epidemiology, and an epidemiology that I think is increasingly defined by exclusion and poverty. And the social risk factors that we're talking about in this presentation, I think are global phenomena, but they're poorly documented. I'm going to use a study that we've done to basically just highlight some of the findings, some of the changing epidemiologies that were particularly amongst the most poorly served populations. And then really, I want to provoke a bit of discussion in terms of what this potentially means or what this could mean in terms of the future of TB control. So we've seen in London a recent decline in the incidence of disease. We've gone from about 3,500 cases in 2012 down to nearer 2,500. But this decline is almost exclusively attributed to a reduction in the number of cases amongst people who are recent arrivals in the UK. We've in fact seen very little to no change in the rate of disease in the UK-born population. But this red line across the bottom is basically the proportion of cases who've got social risk factors. We didn't start collecting this data until about 2009. There was no routine surveillance of the sort of social epidemiology of TB in the UK until quite recently. So what I'm going to share with you is really the first sort of insight into the surveillance data that actually looks at those social risk factors. And what are they? They're principally homelessness, they're alcohol misuse, drug misuse, and imprisonment. They're poorly defined. They're invariably relevant to a current event. And again, I'd like to touch on the need for perhaps better definitions. Better definitions equals shared understanding of what I think is a global issue. The study included about 13,000 cases, and we just used a classic regression analysis to examine what the effect of the risk factors had on your risk of being AFP positive at diagnosis, INH resistance, MDR disease, non-adherence, and your failure to complete an uninterrupted course of treatment within a year. So without further ado, about 1 in 10 at that time had one of these social risk factors. We believe that's quite an underestimate. You can read the numbers in terms of the number who are homeless, number who are in prison, drugs and alcohol. But cut to the chase, through the regression, homelessness comes out clearly. We know this. Twice the risk of being infectious at diagnosis. There was a significant interaction with drug use, unsurprisingly. Obviously, these risk factors compound one another and overlap. Drug resistance was a bit eye-watering. 1 in 5 of the cases who were reported as homeless were resistant to INH, and 5% MDR. We've got the largest outbreak of INH-resistant TB ever documented in Western Europe, and it's fueled by drug use. The common factors with the outbreak are a history of imprisonment and drug use. We believe there's a powerful association between drug networks, particularly crack cocaine networks, and a risk of onward transmission. We saw birth in specific areas of the world where we know there's high rates of MDR-TB, but this was a lower adjusted odds. Previous history of TB, we would expect to see again a lower adjusted odds, and recent migrants more likely to have MDR. But these are independent associations. These are adjusted odds ratios. So what I'm simply saying is that after I've control for origin, ethnicity, previous TB, homelessness remains an independent risk factor for MDR and INH-resistant TB. Non-adherence to course of treatment. Huge gradient in terms of the social complexity of the cases. What we're seeing is more cases reporting 1, 2, and 3 or more risk factors. So we saw about 16% poor adherence amongst people reporting one of these risk factors. But if you get all 4, we're seeing 83% a rate of poor adherence. And homelessness, again, as an independent risk factor, has a 10-fold risk of non-adherence in London. Failure to complete treatment, top of the list, homelessness. Older age, over 65, you'd expect to see that due to the high rate of death events. People of Eastern European origin, recent migrants again, and being male. But top of the list, homelessness. So what am I talking about? Well, really I'm talking about a series of sort of social and behavioral forces that basically drive risk of transmission, drive risk of delayed diagnosis, and drive poor outcomes to treatment. And these risk factors interact with one another in ways that we don't fully understand, but they certainly compound one another to increase risk. And as we kind of journey to the center of this Venn diagram here, I think what we'll see is a clear gradient in terms of R0. What we'll see is a higher risk of onward transmission, a higher force of infection. I wasn't able to include strain data in the results I've just shown you, but there is work going on in London that corroborates what we're thinking, what we're seeing. And lo and behold, the window that the strain data provides enables us to see that if you've got social risk factors, you're far more likely to be part of a cluster, you're far more likely to be associated with recent onward transmission. So let's look at it in context, the sort of post-austerity effect. Since 2011, the population of rough sleepers, that's people who are at the extreme end of the wedge in terms of homelessness, that's people who are on the street. That population's doubled in London in the last few years. And there's some evidence that the mean age of that population's coming down. But who are they? I mean, I'm not here to talk to you about origin. I'm not here to talk to you about ethnicity. I'm not interested in that. I'm interested in the social gradient, the social dimension of TB. The rough sleeping population in London is about 50% UK born, but a very high proportion of people actually come from countries where there is a high rate of MDR disease, and they find themselves in this crazy situation of not being able to access any kind of material welfare or support. So they're entitled to TB treatment, but you can't do that on the pavement. We've had to set up a number of initiatives, not least a TB hostel, to try and support people who are diagnosed in London. So in summary, as we move into a discussion period, I hope, homelessness as an independent risk factor in London, this convergence of risk, the most clinically complex form of disease in the most socially vulnerable people. Twice the risk of being infectious at diagnosis, 3 times the risk of having multi-drug resistant TB, and 10 times the risk of poor adherence, and 3 times the risk of a failure to complete treatment. So what are we talking about here today? We're talking about global TB. Now, I'm very fortunate to live in a rich country. I'm very fortunate to be able to spend inordinate amount of money on surveillance and to include these social risk factors and to have a laboratory system that can actually not only provide DST, drug susceptibility testing on the cultured organisms, but also provide the strain data increasingly to sort of give us the resolution as far as what's happening in terms of the transmission dynamics. But this is a global phenomenon. I mean, the last estimate of homelessness as a concept globally was way back in 2005, and it was well over 100 million people. the street population in major urban cities all over the world is going through the roof. This precariousness, this vulnerability is where we know TB's found its niche. But I don't think we talk enough about the fact that this is where MDR TB finds its niche. This is where pre-XDR-T and XDR TB finds its niche. This is where the most difficult to treat forms of TB find their homes in the most vulnerable and hard to reach populations. And I think going forward, I think we need a shared understanding of what we mean by homelessness. I'm talking about people sleeping rough on the streets of London, but we've heard some wonderful presentations this morning about people in extremely precarious social circumstances in slum settlements, people whose housing circumstances, whose living circumstances are highly conducive to a delayed diagnosis, onward transmission, and an ability to complete treatment. So I'd like to acknowledge my co-authors, Andrew Hayward, Sarah Anderson, Charlotte Anderson, and Helen Maguire. I'd like to acknowledge you for listening, and thank you very much.
Thanks so much, Al, for this very nice presentation about the situation here of the high-risk population in London. So we have almost 20 minutes for the discussion. We would like to invite to use any of the microphones that you have here, and then you can ask the questions or the comments, and then after we will invite the speakers to respond each of the questions or comments that you would like to ask. So the floor is yours. I don't know who we can invite to say something. The floor is open.
Hi, good morning. Thank you so much for these presentations. They're very interesting. I guess I would love to hear some perspectives on what are some of the strategies that you use for populations who actually don't stay in the cities at night, and so how do you reach them if they're actually not living in those sites? Thank you.
Thanks. Any other question, comment?
Thank you so much. Mine goes to my colleague in Bangladesh. From your table of achievements, you had 17,525 presumptive TBs, and you got 5,000 cases. It's about 30%. It's good work, but I think your index of suspicion is quite low. We would expect more presumptives for you to come out with this number of cases. And for your contact investigations, was this cross-sectional or longitudinal? And finally, to the presentation from the UK, how did you categorize alcoholism? Thank you.
Okay, we have other person here? Other question? Yeah, for Kabul from London.
Good morning. Thanks for all the presentations. My name is Jared de Vries from KNCV. I have a question to the UK speaker. Al, you mentioned all the risk factors related to the person, but you didn't mention anything about the system factors. So as you mentioned about homelessness having more frequently smear-positive TB, it also tells something of not having access to health services, and in particular, not completing treatment is also related to the support given by the health service. I've been working in Rotterdam, and I think we came close to have the same treatment outcome with homeless populations than with people who were not homeless. So I think there's also a factor which is the health system supporting patients to complete treatment or having early diagnosis of treatment. Thank you.
Thank you for a nice presentation. My question goes to Mugabe from Kampala and also Kabul concerning the high attrition of staff. We're talking about the high turnover. Kampala intend to have more equipment. But my question is, what are they doing to retain the lab technicians so they can detect because all the indicators are improving, but case detection is not showing any improvement. So how are they going to retain the lab staff to do the work?
Thanks. Any other question or comment? Okay. Who would like to invite to Frank from Kampala, maybe to respond or to comment? You can use the microphone, please.
Stuck up there.
Okay, excuse me.
Sorry. Deborah from the London School of Hygiene and Tropical
Can you use the microphone, please? Thanks.
Too short for that. Sorry, so two questions. The first question is for Dr. Rashidi about his presentation.
Siddiq.
Kabul?
Yes, Siddiq.
Siddiq. Oh. And the second one is for Alistair. So about Kabul, my question is, I'm sorry I was late, so I might have missed that, but Afghanistan had one of the largest food assistance program to TB patients, and I believe this has been discontinued. So I wanted maybe Dr. Siddiq to comment on the effect that that could have had on TB detection and TB outcomes. And a second question for Alistair. So we are in the UK, we are collecting information about specific social risk factors, but we know that, especially with austerity and the change in economics in the UK, there are large segments of the population that now are being pushed into poverty. So while we are looking at specific individual risk factors, maybe we are not really able to capture poverty in all these multidimensional aspects. And so if you could comment on that, and what are we planning to do in terms of surveillance to be able to capture that? Thanks.
Thanks. No more comments? Okay, let us go to the answers, and then we can, maybe I think that we have a time for a second round. Okay.
Starting with the retention of laboratory staff, it's a difficult question. It's a, yeah, of course, but as the TB program, the best way we can retain laboratory staff is to make their working conditions better. Our laboratory staff these days are better using a gene expert to diagnose TB than when they are doing sputum smear microscopy. And I think continuous improvement of their working environment. We are not offering really competitive salaries or what that we can say we shall retain the staff. And also sensitizing them to be patriotic, to know that whatever they are doing is for the good of their country. I wanted to say something about management of patients that are outside Kampala. In Uganda, we have, routinely we have quarterly data exchange activities which bring together different districts from the neighboring areas. But there is also upfront advice that is given to patients when they are diagnosed, because we realize that some people come to Kampala for diagnosis and they want to go back and get treatment. So most of the important things we are doing is that people are educated upfront, because people can come from anywhere to get a diagnosis and want to go and continue treatment. So there are transfer and linkage forms that these patients are given. And second, on a quarterly basis, the district and regional TB focal persons are able to sit and exchange data before the final performance reports are put out. Thank you very much.
Thanks, Frank. Dr. Siddiq from Afghanistan.
Thanks. Three questions addressed to me. First was regarding the turnover of staff. You know, the turnover of staff is not under control of NTP or Ministry of Public Health of Afghanistan. According to the human right, if the person has interest to continue work as okay. On the other hand, by pressure, we not do continuous to see, for example, to do any pressure to health worker to please continue our work. Because you know, Ministry of Public Health of Afghanistan has developed a strategy by the name of Basic Package of Health Strategy, another is initial package for hospital. For basic package of services, all the health is contracted with NGOs. The mostly staff who are working in the health and structure in Afghanistan, they are contracted out with BPHS implementary and NGOs. If, for example, some NGOs just provide more money to another NGO, smoothly the health staff has left job and joined to another organization. But the turnover of staff is, don't means that they don't have any knowledge for tuberculosis, because they are inside of the system, they are left one NGOs and joined to another NGOs, but all of them in the past received initial DOTS training, is no problems. But when we see, for example, the number of turnover of staff is so high. The second question is regarding the case detection and outcome. I accept since we started after the establishment of new government in Afghanistan, we started the TB program from zero after the collapse of Taliban. And please note that Afghanistan, Syria, and Iraq, they are the top 3 unsecure countries. It's not stable countries, and working in those 3 countries with high bad situation, security bad situation is not easy work. And this purpose, we try our best to increase our case detection, but fortunately, we have very good treatment success rate. That means when in the main city or in far when we started the treatment for any TB patient, they are started and completed their own treatment. And the third question is raised by my colleague. I accept when we see, for example, the patient when there is as a presumptive TB patient is registered, but the case finding is not so good. But you see the situation of Kabul city as an example, because there's a private sector and also private hospital. They are so strong, and also anti-TB drugs is available in all over this big city. And unfortunately, you know, there's a tuberculosis a stigma when we ask from private laboratory technician to join for TB program due to infection purpose, they are not accept to continuous work with tuberculosis. There is all of these factors, they are have that for the case, low case finding in this way. Thank you.
Al?
Yeah. Well, firstly, the alcohol question is very. I mean, it's a challenge, isn't it? We need to think about definitions that actually not only work in terms of we can share across quite wide social geographies, but we need to think about definitions that actually don't just measure something for the sake of surveillance. They actually inform action. They inform patient care. So, I mean, we struggle with a good definition for alcohol. Alcohol, is a very relative thing. I mean, to a certain extent, the most accurate definition for alcoholism is someone who drinks more than their doctor. But, we can't really... that's difficult to apply internationally. But there are some pretty good validated tools like Audit C, FAST, etc., that genuinely inform action. They inform care. So, yes, we need surveillance definitions that inform action, that inform care. Second question from Gerard in terms of the system. We heard I think a consensus from all the talks this morning. People know what they need to do. Everybody knows what they need to do. They know how to reduce barriers to care. They know how to target people who are most at risk. We have the technologies to take diagnostics to the street, to outreach to where things are most needed. But where's the political will to actually do that? Trying to control TB in the engine house of transmission, where MDR an XDR-TB is getting a foothold, is not going to be cheap, but it's certainly going to be very good value for money in the long term. And the program factors are clear, the system factors. It's active case finding, targeted active case finding. It's a more intense approach to supporting people through treatment. It's not a one-size-fits-all model. It's not a pill delivery service anymore. It's a service that has to embrace issues like alcoholism, drug use, imprisonment, etc., and the need for accommodation. And lastly, the question on, the poverty agenda as a whole. We've seen through, since the dawn of the dawn of surveillance in terms of TB, and TB is an early disease in terms of surveillance. We've seen a clear correlation between income, between poverty and risk of disease incidence. And we do have quite good measures of deprivation that we can apply to cities, and that is happening nationally and should be used to relate incidents to indices of deprivation. We're kind of in our infancy in terms of understanding how to target active case finding initiatives. We've got to move beyond the day of sitting in a building-based facility and waiting for people to come to us. It's got to be more intelligent, it's got to be more information-driven, it's got to be more targeted. Thank you.
Thanks so much, sir. Well, we have 5 minutes more. Any additional question or comment? Okay.
Maybe before that,
Yeah.
there was one question for Dr. Sadiq. I'm not sure if you addressed. The question is the impact of discontinuation of food support in Kabul. What would be the impact on your TB program? There was a question on that.
Wait, please. Hold on, please.
Thank you. Fortunately, regarding the TB program, we have a very good partner. The partner of National TB program is USAID, MSH Challenge TB, JICA, WHO, Global Fund. But the impact of the support of NTP partner, just I present the model of Kabul city, because in 2009 we had the situation, but by the support of Challenge TB, you saw the situation and is improved. But because since 13 years I working as NTP manager for Afghanistan, in 2001, just only in Afghanistan, we had 12 centers for TB diagnosis and treatment. But right now, we have more than 2,000 centers for treatment and diagnosis of TB patient. And 2001, the total number of notified by TB program on that time was 9,831. But in the end of 2015, the number is more than 42,000. But you see, all of them is the achievement is the support of NTP partner. But I wish the continuation of the support of NTP partner. But the good news is that we have Challenge TB in the end of 2019. We have JICA for another 3 years, and we have planned to develop proposal for new grant of Global Fund 2017-2020. And also in addition of NTP partner, the political support and top leadership of the Ministry of Public Health is supporting National TB program of Afghanistan.
Thank you, Dr. Sadiq. The floor is yours.
Yes, Ikushi Onozaki, WHO. So I want to mention about the role of the industry, so employers, actually, because we conducted TB prevalence national survey in more than 20 countries. In most countries, despite our actually expectation that because of the better access, urban prevalence should be lower than we expected, but actually most of the countries that carried out survey, so prevalence of the urban area is much higher than rural area, including Uganda. That's Frank just completed the survey. So actually, patients are not homeless. actually even aging the program in many places, but actually in urban area, patients are young or reproductive age, and most of them are male. So they're actually working. So in the country where actually some organization like Union, not the International Union Against TB, but the labor union, or even the government have some government order, not by Ministry of Health, from Ministry of Labor, to enforce some protection of the workers or prevention and guarantee the treatment of TB, so on, then actually those groups, then we really don't see TB patients, much less. But majority of the actually workers are not protected. We really need to see, especially in urban area, such kind of aspect, not only by health sector, but also laborers and approach to some employers or labor union. Thank you.
Thanks so much. We have 2 minutes. Let us summarize this discussion. I think that this was a very interesting and important conversation about colleagues of coming from different health system environment and social and economical situation. And what we would like to say is that this is a global problem, but the solution should be tailored to the country situation. It's very specific based on the situation of each country. However, based on the presentations, we can agree that the first and most important activity or intervention should be to organize a very good situation analysis to understand the problem at the specific urban area. Then prepare a very comprehensive plan which should involve not only the traditional TB control program, all the other social and economic partners, and also international partners, and then be very systematic in the implementation of this plan. And this plan should really be very focused on the high-risk population, and based on the new evidence that we have for several studies, we really push the implementation of very innovative approach and the new technology, like gene expert, digital array, the new technology, like, for example, mobile technology, to ensure that we will use all the resources that we have now available, not only for the TB side, also for the health system at all. I think that we are almost over the time. I don't know if you...
Very quickly, in response,
you want to say something?
just in response to the last comment on the prevalence survey, and I think most people would agree with the logic of this statement. I mean, the barriers to accessing diagnostics and treatment are quite clearly defined, and they're probably the same barriers to accessing participation in a prevalence survey. So again, the prevalence surveys, to a certain extent, will likely reflect those populations who are able to reach services and diagnostics already. They do not outreach to actually measure the prevalence of disease in the risk groups. Thank you.
Thanks. See you.
Yeah, thank you very much and for the participation. I think we need to keep learn from this experience. I think it is a rich experience, and let's keep sharing the information. Thank you very much.
Thanks so much.